Hi, hello. I'm Monica Talafari, consultant midwife working in the UK, and I'd just like to thank the organisers for inviting Lynn and I to this online global nursing webinar. I'm about to speak about a subject which I'm absolutely passionate about, but more importantly, a subject which involves women and women's health, particularly women of childbearing age. Firstly, I will do the first part of the presentation. Lynn will do the second half, and we'll take it from there. So let's get started. Care of the uterus in labour to reduce the incidence of PPH, in other words, postpartum hemorrhage, when using unlicensed dilutions of synthetic oxytocin. For those that don't know what syntocinon is or what synthetic oxytocin is, it's basically a hormone called oxytocin. And there are two types. Well, not kind of really, but one's a natural type, which every woman has. And then there's the one like the synthetic type, which is injected into you. And it's used for labour, induction of labour, and helps the uterus or womb to contract and the cervix to dilate in order that the baby can come out after 9 months being stuck in that lovely womb. I thought I'd just look up the stats for just the year 2021, and we had 11,377 births per 1,000 women for the year 2021. So during the pandemic, the birth rate went down, which is kind of understandable, especially because you don't know what's going to happen. Every year in the UK, 1 in 5 labours are induced. That is, that their labour has been artificially started. But 1 in 5 is actually quite a lot of women in the UK. Caring for the woman and her uterus is a global issue and a human rights issue as well. As I mentioned before, oxytocin is a hormone used to induce labour and dilate the cervix. It is known to cause pain in labour, which may require an epidural to numb the pain. Women need to consent to the use of oxytocin, especially if she's being given an unlicensed regime. Women need to be consented, probably twice in labour, because they need to be consented for the licensed dose and dilution, but also if they're given any drug that is unlicensed. This is a whistle-stop tour really, but we started off with the hypothesis, I never get that word right. If women are given the licensed dose and dilution, the postpartum hemorrhage rate, PPH, rate would fall to single percentage digits, as seen in the past, which were 3 to 4%. But now they're in double figures. So the question that I asked, and we both asked really, why are PPH rates on labour ward 10 times higher than they could be? When I came into midwifery in 1983, we were given the licensed dose, the dilution, and the increments, and also we could titrate oxytocin up and down so that we would maintain the woman's contractions to be around 1 in 4 ratio. That way, we prevented overdosing and tetanic contractions and always stayed with the woman whilst she was on the oxytocin drip. We actually advocate one-to-one midwifery care, but we understand that that's a real challenge in the NHS right now. What we found was that the less is more effective, and that's what we call caring for the uterus. Oxytocin given in excess, causing tetanic contractions and fetal distress. Well, I mean, it can cause tetanic contractions. What are tetanic contractions? In other words, it is a constant, sustained contraction of the uterus or the womb, which leads to fetal distress, and you really don't want that. I mean, let's face it, if you're a baby, or a fetus for that matter, coming through the womb, you don't want your oxygen supply cut off whilst you're desperately trying to fight to get out of that lovely womb. Here we have figure B, and you can find it on the website oxytocinmeasures.com. This table shows the full license dilution, and the license dosage is 5 IU of oxytocin, synthetic oxytocin, in 500 ml of Hartmann's or normal saline or whatever you use. Here you have the full range of doses that can be given. All of these doses can be given. But what we have currently is the RCOG regime highlighted in blue, which is you can start at 1, 2 or 4 and then go into 8, 12, 16, 20, 24, 28, 32. The maximum dosage is 20 milli-IU per minute. So what are these doses, 24, 28 and 32, what are they doing in the regime? All these other doses are omitted. They're not used. Desensitization of uterine oxytocin receptors. Now, I haven't got a lot of time to go through this, so I'm going to give you the bare minimum. In 2016, I spoke to Professor Leng, Gareth Leng, and he's basically a professor of experimental physiology at Edinburgh University. We spoke again to him in September, I think it's 2019, Lynn and I, and we were working on our article, which we published in October 2021. And we really wanted to understand this, and we wanted to learn more about how oxytocin works on the uterus. So we asked the question. In fact, it was a few questions that we asked, and the question goes like this: Does giving oxytocin too fast inhibit the oxytocin response? I say that again, it doesn't come out quite clearly. Does giving oxytocin too fast inhibit the oxytocin response? So I'll read the slide now. Oxytocin acts on oxytocin receptors. Okay, the more oxytocin there are in the tissues, the more sensitive the tissues will be. So if you give oxytocin at a time when there are not enough receptors to trigger contractions, you need to give them enough oxytocin to activate the receptors, but not so much that you desensitize them. So in other words, desensitizing the oxytocin receptors can lead to PPH. And I think I'll leave it there for Lynn to take over from now. So, desensitizing oxytocin receptors in the womb can lead to PPH. And I think I'll leave it there because we're running out of time. I want to thank you for listening, and let's go to Lynn's presentation right now. Before we go to that, I want to remind you that the birth rights video link is just here in the bottom of the presentation. And over to you now, Lynn.